Your doctor handed you that prescription slip, looked you in the eye, and said, take 1 tablet every morning. So, like millions of adults over 60, you added it to your daily routine, swallowing it faithfully alongside your morning coffee. But here is the chilling reality your physician almost certainly omitted. That exact routine might be leaving your cardiovascular system completely defenseless during the most perilous hours of the day. We aren't talking about a minor fluctuation in efficiency. Clinical data tracking tens of thousands of patients reveals that the hidden mechanics of medication timing can mean the difference between robust arterial protection and an unexpected midnight trip to the emergency room. There is an invisible architectural flaw built right into the standard morning dosing schedule, an error that inadvertently exposes your heart and kidneys to catastrophic pressure spikes. I'm Dr. Liam Cooper. Over my 2 decades as a cardiovascular researcher and clinical advisor, I have watched thousands of patients meticulously follow their prescription labels, completely unaware that their breakfast habits, fluid intake, and sleeping schedules were actively neutralizing their treatments. I created this space because the vital, life-saving nuances of your cardiovascular health deserve more than a rushed 10-minute clinic appointment. The traditional one-size-fits-all morning recommendation is rapidly crumbling under the weight of modern chronobiology. Over the next few minutes, we are going to dismantle the 5 profound timing errors that compromise your safety every single day, starting with the deeply deceptive mistake currently hiding inside your morning ritual. To truly grasp why your morning routine might be setting you up for a cardiovascular crisis, we have to look at the rigid, uncompromising clock ticking inside your chest. Your blood pressure does not maintain a steady, flatline equilibrium throughout a 24-hour cycle. Instead, it operates on a highly sophisticated internal schedule governed by your circadian rhythm. In a young, healthy individual with highly elastic blood vessels, blood pressure naturally plummets by 10% to 20% the moment they fall asleep. In the medical community, we refer to this vital nocturnal drop as dipping. However, as the night begins to transition into dawn, specifically between the critical hours of 4 a.m. and 10 a.m., your endocrine system releases a massive surge of cortisol and adrenaline. These hormones act like an internal alarm clock, signaling your sympathetic nervous system to step on the gas pedal. As a result, your heart rate accelerates and your blood vessels constrict to prepare your body for the physical demands of waking up. This sharp, dramatic escalation is known as the morning surge. Here is where the hidden danger manifests for those over the age of 60. Over decades of life, our arterial walls naturally lose up to 30% of their structural elasticity due to a process called arterial stiffening. When a rigid, hardened arterial system is suddenly subjected to the violent pressure spike of the morning surge, the vascular walls undergo severe mechanical stress. It is not a coincidence that robust epidemiological data shows this exact morning window is responsible for nearly 50% of all strokes and 40% of all acute myocardial infarctions, heart attacks, within any given 24-hour period. Now consider the profound structural flaw of a standard morning prescription. If you swallow your blood pressure medication at 7 a.m. or 8 a.m., the pill must first pass through your digestive system, dissolve, and undergo hepatic metabolism. It typically takes between 1 to 3 hours for most antihypertensive drugs to reach peak therapeutic concentration in your bloodstream. By the time the medication is fully armed and operational at 10 a.m. or 11 a.m., the most dangerous, high-risk window of the morning surge has already passed. Worse yet, by the time 4 a.m. rolls around the very next morning, the precise moment the next day's lethal surge begins to build, that morning dose pill has been circulating and decaying in your system for over 20 hours. The concentration of the drug in your plasma has hit its lowest absolute point. In essence, the standard morning dosing schedule ensures that your chemical defense system is at its absolute weakest, exactly when your cardiovascular vulnerability is at its absolute peak. You are essentially leaving your arteries completely unshielded during the exact hours they are most likely to rupture or clot. Let us dissect the first major timing mistake, one that is likely occurring on your kitchen counter right now: pairing your morning beta blocker with your first cup of coffee. Millions of adults take medications like metoprolol, atenolol, or carvedilol and immediately wash them down with or drink right after a hot cup of coffee. To understand why this is a clinical disaster, we have to look at how these two substances fight for control over your heart. Think of your sympathetic nervous system as your body's internal accelerator pedal. When you consume caffeine, it triggers a rapid release of adrenaline and blocks adenosine receptors, forcing your heart to beat faster, strike harder, and temporarily spike your systemic blood pressure. Beta blockers are designed to do the absolute opposite. They act as a biochemical brake pedal, binding to beta-adrenergic receptors to slow your heart rate and lower the force of each contraction, protecting your muscle walls from strain. When you introduce coffee and a beta blocker into your stomach within the same 30 to 45-minute window, you are simultaneously slamming on the gas pedal and the brake pedal of your cardiovascular system. For a younger patient, this might just cause a muted drug effect. But past the age of 60, this internal tug-of-war can have destabilizing consequences. While the medication usually wins the structural battle over a few hours, the immediate competition during caffeine's peak absorption window, roughly 30 minutes after drinking it, can trigger cardiac irritability. For anyone with a history of an underlying arrhythmia, such as atrial fibrillation or premature ventricular contractions, this sudden, simultaneous push and pull can trigger symptomatic heart palpitations. A major data analysis tracking thousands of patients on beta blocker therapy revealed that individuals who consumed heavy caffeine within an hour of their dose experienced a 22% higher incidence of fluttering, irregular beats, and chest discomfort compared to those who spaced them out. It isn't that the coffee destroys the pill. It's that the sudden metabolic conflict creates a window of electrical instability in an older heart. The solution here requires zero cost. Just a shift in your morning timeline. If you are prescribed a beta blocker, you must enforce a strict 45-minute barrier between your medication and any caffeinated beverage. Allow the tablet to clear your stomach and enter your upper intestine unhindered. If you absolutely cannot wait for that morning ritual, switching to a true decaffeinated coffee eliminates the risk, as it lacks the chemical stimulants that triggered this specific receptor conflict. Furthermore, always take your pill with a full glass of plain water. Consistent hydration ensures predictable gastric emptying and prevents erratic spikes in drug concentration. This brings us to a far more sinister interaction, one that completely shatters the metabolic defense systems of your digestive tract. The hidden conflict between grapefruit products and calcium channel blockers. If you are taking common medications like amlodipine, nifedipine, or felodipine to manage your vascular tone, an innocent glass of juice or a morning fruit salad can turn a standard therapeutic dose into an accidental, toxic overdose. To understand the mechanics of this threat, we have to look at the protective barrier inside your small intestine. Your body utilizes a highly specialized detoxification enzyme called CYP3A4. Think of this enzyme as a strict security checkpoint at the border of your bloodstream. Under normal conditions, when you swallow your calcium channel blocker, this enzyme deliberately metabolizes and destroys a significant percentage of the drug, allowing only a precisely calculated safe amount to enter your systemic circulation. However, grapefruit and its juices contain a highly potent class of organic compounds known as furanocoumarins. The moment these compounds enter your digestive tract, they structurally bind to and permanently deactivate the CYP3A4 enzymes at that intestinal checkpoint. They don't just temporarily block the security guards, they completely dismantle them. Because your body must synthesize entirely new enzymes to replace the damaged ones, this metabolic checkpoint remains completely broken for up to 72 hours after a single serving of grapefruit. When you take your next dose of amlodipine while that checkpoint is down, the medication floods into your bloodstream entirely unchecked. Instead of the intended safe dosage, the concentration of the drug in your plasma can violently spike to 2, 3, or even 5 times the medically prescribed limit. Because calcium channel blockers function by forcing the smooth muscle walls of your arteries to relax and widen, this massive, unregulated surge causes a catastrophic drop in your systemic blood pressure. For an individual over the age of 60, this sudden, profound hypotension does not just cause mild lightheadedness, it directly cuts off critical perfusion to the brain. When you stand up from a chair, your stiffened blood vessels cannot constrict fast enough to fight gravity, leading to severe orthostatic instability, syncope, fainting, and dangerous, bone-shattering falls. Clinical pharmacology units tracking this specific phenomenon have documented a 31% higher rate of emergency hypotensive events in patients who consume grapefruit products within that 72-hour vulnerability window. The clinical protocol for this mistake is absolute and non-negotiable. If you are prescribed any calcium channel blocker, grapefruit must be permanently banned from your dietary routine. You cannot simply space it out by a few hours, because the enzymatic disruption outlasts the day. Replace those breakfast citrus items with safe alternatives like orange juice or apple juice, which carry no furanocoumarins. Additionally, consider speaking to your provider about optimizing your dietary magnesium. Consuming magnesium-rich options like spinach or almonds alongside your care can naturally support vascular stability without interfering with your prescription's metabolic pathway. The third critical timing error is perhaps the most physically devastating for older adults, yet it is routinely caused by a simple lack of instruction at the pharmacy counter. This involves the mistiming of diuretics, commonly referred to as water pills. Millions of seniors rely on medications like hydrochlorothiazide, furosemide, or chlorthalidone to manage volume-dependent hypertension. These drugs operate by signaling your renal system, your kidneys, to accelerate the filtration and excretion of sodium and fluid from your bloodstream. Think of your circulatory system like a pressurized garden hose. By reducing the total volume of water traveling through the hose, you instantly lower the physical pressure pushing against the interior walls. It is a highly effective mechanism, but because these medications actively force fluid into your bladder, their operational timing dictates exactly when you will be forced to evacuate that fluid. The crisis occurs when a patient forgets their morning dose and takes it at 5 p.m., or when a prescription bottle simply reads, "Take one daily," without specifying a time, leading the patient to take it with dinner. When a diuretic is introduced into your system in the late afternoon or evening, the drug hits its peak physiological effect right in the middle of the night. Your kidneys work overtime while you sleep, rapidly filling your bladder and forcing you to wake up at 1 a.m., 2 a.m., or 3 a.m. to use the restroom. Waking up multiple times a night disrupts your deep sleep architecture, but the true medical danger lies in what happens the moment your feet hit the floor in the dark. As we age, our baroreceptors, the internal pressure sensors in our neck arteries that tell our blood vessels to constrict when we stand up, become sluggish. When you stand up rapidly from a flat position in a dark room, gravity naturally pulls blood down into your lower extremities. Because the diuretic has actively depleted your fluid volume and your baroreceptors are slow to respond, your blood pressure plunges instantly. This induces severe orthostatic hypotension. In the darkness, slightly disoriented from interrupted sleep, the patient experiences a sudden wave of dizziness, loses their balance, and falls. The National Institute on Aging has long warned that nighttime falls are the single greatest catalyst for hip fractures in adults over 70. This is not just an issue of minor bruising or temporary immobility. Data demonstrates that a hip fracture past the age of 70 carries an astonishing one-year mortality rate of 20% to 30%. 1 out of every 4 seniors who fractures a hip due to a nighttime fall will not survive the following 12 months due to subsequent surgical complications, infections, or prolonged immobility. Harvard-affiliated clinical reviews analyzing nearly 15,000 patients on diuretic therapy confirmed that individuals taking their water pills after 2 p.m. experienced a 44% higher rate of emergency room-level nighttime falls compared to morning dosers. The clinical rule is absolute. Your primary diuretic dose must enter your system before 10 a.m. If you are on a twice-daily regimen, the second dose must be taken no later than 2 p.m. to ensure the drug's fluid-clearing cycle concludes long before you head to bed. The fourth profound timing mistake involves the high-stakes gamble of dose doubling after a forgotten pill. It is a scenario almost every patient faces eventually. You glance at your pill organizer at 3 p.m. and realize you completely forgot your 8 a.m. dose. Your natural human instinct is to compensate for the mistake, so you think, "I'll just take 2 doses tonight to catch up and make sure my blood pressure stays under control." While this might be a forgivable strategy for certain mild vitamins, applying this logic to advanced antihypertensive medications like long-acting angiotensin receptor blockers, ARBs, such as valsartan or losartan, or calcium channel blockers, can trigger an acute cardiovascular emergency. To visualize what occurs inside your body, look at the intricate layout of your arterial tree. Your blood vessels are wrapped in a layer of smooth muscle that maintains a precise amount of resting tension to keep your blood moving. Medications like ARBs work by chemically blocking angiotensin II, a highly potent hormone that forces those smooth muscle walls to clamp down and constrict. One single metered dose relaxes those vessels gradually, allowing blood pressure to glide down into a safe therapeutic zone over several hours. When you introduce a double dose into an aging vascular system, you completely overwhelm those smooth muscle receptors. Instead of a controlled relaxation, your arterial tree experiences a sudden, massive collapse in structural resistance. Because adults over 60 frequently have reduced overall vascular tone and varying degrees of underlying plaque accumulation in their carotid or coronary arteries, their bodies cannot rapidly adapt to this sudden drop in pressure. Your systemic blood pressure bottoms out, resulting in profound hypotension. This sudden drop deprives your vital organs of adequate oxygenation, leading to a condition called ischemia. Instead of protecting your brain and heart, that well-intentioned double dose can cause sudden fainting, a transient ischemic attack, a mini-stroke, or even a myocardial infarction due to low blood flow. Large-scale data tracking from Johns Hopkins University revealed that patients who doubled their doses after a missed pill experienced a 38% higher rate of emergency hypertensive crises and acute syncopal events compared to those who maintained strict single dosing. The secondary mutation of this mistake is equally widespread. Patients who are prescribed a twice-daily medication but unilaterally decide to take it once a day because managing two separate times is too inconvenient. They take the full daily amount in one single sitting without informing their physician. When they visit the clinic, their spot blood pressure reading might look acceptable on paper, masking the underlying issue. However, because the medication was biochemically engineered with a short half-life, its protective coverage wears off halfway through the day. For the remaining 12 hours, their heart, brain, and kidneys are left completely exposed to silent, unmanaged pressure damage. The data shows that inconsistent twice-daily dosers face a 26% higher rate of cardiovascular-related hospitalizations. The clinical protocol for a missed dose is rigid. If you remember your forgotten pill on the same day, take it immediately, unless your next scheduled dose is less than 4 hours away. If you are within that 4-hour window, you must completely write off the missed dose, leave it in the box, and resume your normal schedule. Never make an executive decision to double up without speaking directly to your pharmacist or provider first. To safeguard against this entirely, utilize behavioral anchoring. Set a recurring alarm on your phone and tie the act of taking your medication to an unshakable daily habit, like completing your breakfast or brushing your teeth. Studies tracking medication adherence show that pairing your pill with a fixed behavioral anchor reduces the incidence of forgotten doses by a massive 63%. We have now arrived at mistake number 1, the widespread, unexamined belief that morning dosing is automatically the safest option for everyone. For decades, taking blood pressure medication first thing in the morning has been the default medical instruction. However, modern clinical science reveals that this routine can leave many patients vulnerable when they need protection most. To see why, we have to look at what happens over a full 24-hour cycle. When a patient takes an ACE inhibitor or an ARB at 8 a.m., the drug reaches peak levels in the blood by midday. By 5 a.m. the following morning, the medication has been breaking down in the body for 21 hours. As a result, its protective effect drops to its lowest level, right when the early morning blood pressure surge begins to build. Shifting the dose to bedtime completely flips this timeline. Taking the medication at 10 p.m. allows it to reach peak concentration in the bloodstream between 2 a.m. and 4 a.m. It meets the dangerous morning surge with maximum structural strength, keeping blood pressure stable during those high-risk early hours. The impact of this timing shift was highlighted by the Hygia chronotherapy trial, which tracked 19,084 adults over 6 years. The data published in the European Heart Journal showed that patients who took their medication at bedtime had a 45% lower risk of cardiovascular death, heart attack, or stroke compared to morning dosers. Additionally, a large meta-analysis in the Journal of the American Heart Association confirmed that evening dosing provided significantly better control over nighttime blood pressure and the morning surge. However, it is important to note that the science on this is still evolving. Other large-scale clinical trials, such as the Time study in the United Kingdom, which followed over 21,000 patients, found no significant difference in long-term cardiovascular outcomes between morning and evening dosing. This tells us that medication timing is not a one-size-fits-all rule. It depends entirely on your unique body. The only way to map your specific rhythm is through a 24-hour ambulatory blood pressure monitor, ABPM. As shown in the tracking data visual, a portable cuff takes regular readings while you sleep to reveal your exact patterns. This test identifies if you are a non-dipper, someone whose blood pressure fails to drop naturally at night, or if you experience an unusually sharp morning spike. Your actionable takeaway is straightforward. Do not change your schedule on your own. At your next appointment, ask your doctor if switching to bedtime dosing makes sense for your specific health profile, and inquire if a 24-hour ambulatory monitor could help guide that decision. Managing your cardiovascular health is an active journey, and the choices you make every day around your prescription routine play a vital role. The fact that modern medicine can intervene in our biological rhythms to help prevent strokes and heart attacks is an incredible tool. But like any advanced tool, understanding how to use it safely and effectively makes all the difference. As we age past 60, our vascular needs change. Managing those hidden variables, from the timing of your morning coffee and avoiding grapefruit juice to optimizing your diuretic schedule, is completely within your control once you have the right knowledge. The simple questions you bring to your next doctor's appointment can build a much more personalized, safer approach to your long-term wellness. I want to hear from you now. Which of these timing adjustments or hidden interactions surprised you the most today? Are you currently a morning doser or a bedtime doser? Share your experience and your age in the comments below. Your story might be the exact piece of information another viewer needs to see. If this clinical breakdown gave you practical insights that you haven't heard in a standard clinic visit, please take a moment to subscribe to the channel, hit the like button, and share this video with someone you care about. Thank you for watching. Take great care of yourself, and I will see you in the next video. Clinical disclaimer. The information presented in this video is for educational and informational purposes only. It is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Never disregard professional medical advice or delay seeking it because of something you have heard or seen on the internet. Always consult with your prescribing physician, cardiologist, or pharmacist before making any changes to your medication schedule, dosage, or dietary habits.